Good morning everyone. I will talk about psychological factors in the management of TMD today. So what are the psychosocial factors in the aspect of the TMD treatment? So first, coming to the definition, it refers to the interplay between the psychological and the social factors that influence the pain perception, onset, progression and the management of the TMD. These factors contribute to the pain perception, the pain has evolved, that is its mechanism, treatment response and the overall quality of life in TMD patients. In this, the role of the biopsychosocial model, which was given by Mr. George Engel in 1977, plays a very important role. This model says that TMD results from the complex interaction of biological factors, that is the genetical predisposition, and the psychosocial factors, which will be stress and anxiety, and the social factors, that is the cultural influences and the environmental factors in the management of TMD. This comprehensive approach aids in understanding the individual variations in the TMD experiences and the pain perception. Coming to the key components of the psychosocial aspects in the TMD pain management, first the psychological factors. First come into play the stress and the anxiety, the most important. Triggers the muscle tension in the TMJ and the parafunctional habits which lead to the development of the clenching of the jaw and the bruxism habit in patients. Depression and mood disorders are the second category, which enhances the pain sensitivity and specificity and affects the coping strategies for the pain. Pain catastrophizing, how the pain is felt, the negative thinking about pain and the fear of pain leads to chronic pain in the TMD symptoms, and the cognitive behavioral influences, beliefs and the attributes towards coping mechanism of pain and the shape of the pain experience surfaces come into play. Coming to the second aspect, behavioral and social factors, the parafunctional habits, the repetitive jaw activities, that is a nail biting, gum chewing, worsen the symptoms, and the social support, strong support systems aid in coping, isolation and intensifying of the pain symptoms. Work and the environmental stress, occupational stress and lifestyle habits contribute to TMD, and the cultural and the psychosocial perception of pain. Pain reporting and treatment seeking behavior, how the treatment is given to the patient is also playing a role across the various cross-cultural practices. Coming to the mechanisms behind the role of the psychosocial factors in the TMD, as I told, the psychosocial model explains how the psychological, social and the behavioral factors interact with the biological mechanisms, like how the pain is appearing in the body, contributing to the onset, persistence and severity of the TMJ related pain. First of all comes stress and its activity on the hypothalamic pituitary adrenal axis activation. So the chronic type of stress and anxiety lead to the dysregulation of the HPA axis, which controls the body's response to stress. If stress is there, it activates the release of cortisol and the catecholamines, that is the adrenaline and the noradrenaline, which increase the muscle tension in the masticatory muscles of the jaw of the TMJ and lower the pain threshold, making individuals more sensitive to pain and discomfort. Induce bruxism. When bruxism happens, an unconscious stress relief mechanism also takes place. For this, literature evidence studies by Slade et al. In Pain Journal of 2007 show that patients with TMD have higher cortisol levels, indicating hyperactive stress response. Coming to the depression and the role of central sensitization. Depression is linked to the chronic pain symptoms including TMD through changes in the brain neurotransmitter levels. Reduced serotonin and dopamine levels affect pain modulation in the central nervous system, leading to increased nociception of the pain and pain perception, amplified pain intensity and persistence, which is the central sensitization where it comes into play. Impaired pain inhibition from descending pain pathways in the brainstem. And the neurobiological changes, what happens? The anterior cingulate cortex part of the brain, prefrontal cortex of the brain and the amygdala areas are responsible for the emotional processing of the pain, show altered activity in depressed TMD patients. For this, Kimos et al. Did a study in the Journal of Orofacial Pain in 2009 and related the depression and the central sensitization. Coming to the pain catastrophizing and the cognitive emotional amplification of pain, how pain catastrophizing increases the emotional amplification of pain. So referring to the catastrophizing, that is a negative thought about pain, increases pain perception. Mechanism how the negative catastrophizing occurs, in the portion of the amygdala, that is the fear processing centers, decreased inhibition from the prefrontal cortex lead to an exaggerated pain response, and in the insular cortex increased activity happens which leads to the enhanced pain perception and distress. For this, one study was done for the high catastrophizers exhibiting more pain related neural activity by Viksky et al. In Pain Journal in 2004. Coming to the impact of the coming to the behavioral and the social mechanisms in the TMD. First of all, the parafunctional activity and the neuroplasticity changes. Chronic jaw muscles come to the overuse due to the bruxism, clenching and the excessive gum chewing leads to muscle fatigue and strain, and it gives rise to myofascial pain. TMJ overload. In the disc displacement and the joint degeneration, neuroplastic changes occur in the somatosensory cortex, increasing pain persistence. How it happens? Repetitive stimulation of the trigeminal pathways enhances the pain memory formation, making TMD self-sustaining over time. The neuroplastic changes in the cortical pain processing areas of the brain, that is the motor cortex and the somatosensory cortex, reinforce maladaptive motor habits. The EMG studies have confirmed the hyperactivity in the masseter and the temporalis muscles in the TMD patients, study by Winkonker et al. In the Journal of Oral Rehabilitation. Coming to the sleep disturbances in insomnia and TMD pain, how the poor sleep quality affects the TMD pain perception. The insomnia and the poor sleep quality exacerbate TMD pain through increased inflammatory markers. There is an increase in the markers of interleukin 6, TNF alpha, leading to inflammation, reduced endorphin release, lowering the natural pain perception. Disturbance in the REM sleep patterns, impairing the muscle recovery. Muscle recovery and heating, bruxism and sleep disorders. Sleep-related bruxism linked to the sympathetic nervous system worsens TMD, and studies confirm that the sleep deprivation enhances pain sensitivity and prolongs recovery from the TMD-related pain. Study done by Smith et al. In Sleep Medicine Reviews for in the year 2019. Coming to the social support aspect, stress coping aspect and the TMD pain modulation, lack of social support and ineffective coping strategies contribute to chronic pain persistence. How this mechanism involves social isolation leads to increased activity in the pain processing areas of the brain. High stress levels after the endogenous opioid infusion can counteract the pain TMD amplification. This leads to the clinical implications of patients with strong social networks report lower TMD pain intensity and better treatment outcomes. This study was done by the Germanian et al. In JADA journal, which was published in 2018. Coming to the impact of the psychosocial factors in the TMD pain treatment outcomes. First of all, cognitive behavioral therapy and neuroplasticity reversal comes into a very important role. The CBT interventions reduce the pain catastrophizing, modulating the neural circuits of pain perception. Brain imaging studies and the EMG studies show that the successful CBT normalizes overactive pain processing areas, that is the prefrontal cortex and anterior cingulate cortex in the TMD patients. Orofacial pain specialists recommend the CBT as the first treatment for chronic TMD. This study, the evidence was given by the study in the Psychosocial et al. Journal of Pain Research in 2020. Second comes relaxation techniques used for the HPA axis normalization. The biofeedback mechanism, mindfulness, and the progressive muscle relaxation exercises lower the sympathetic overactivation, which results in reduced masseter and the temporalis muscle activity, lower cortisol levels, leading to improved pain tolerance and regulation of the inflammatory responses. The markers that I said previously will reduce and the TMD pain will subside. Studies confirm that relaxation therapies significantly reduce pain scores in TMD. A study done by Manfrendi et al. In clinical oral investigations in 2022. So coming to the future research directions in the psychosocial TMD pain management, neuroimaging studies have been extensive, exploring how CBT and mindfulness alter the brain circuits in the TMD patients. AI-based prediction models can be developed, integrating the psychosocial aspects and the individualized, personalized treatment. Virtual reality therapy, which will involve the setup of the personalized computer setup and virtual scenarios which can be altered, can emerge as an immersive pain distraction technique in TMD patients. So coming to the conclusion, the psychosocial aspects of the TMD are deeply intertwined with the neurobiological mechanisms influencing pain perception, stress and responses, and the treatment outcomes. A multidisciplinary approach is essential for the behavioral modifications and the stress management techniques for the long-term effectiveness of the TMD pain management. Thank you.